welcome. As Judy said, I've been a nurse for a long time and was an activist with the California Nurses Association for a long time, and they are one of the main groups working to pass Senate Bill 810. So I'm I call myself a politically active nurse. Even though I'm in retirement, I'm still always a nurse. How I'd like to start this out is the Occupy movement both in New York and Denver. Single payer is now being on that platform because the CEOs of the insurance companies are like the Wall Street of healthcare. They make 10 to 14 million a year and yet deny care to a lot of people. So I like to start out saying that our motto is that healthcare is a human right and not get all bogged down with the finances, which obviously are important. But the fact that we have 50 million uninsured in America at this point in time is a travesty. It's a disgrace in the richest country on earth. The wealthy and people who happen to have a job that has good health coverage get the care and the poor don't. And the only venue they have to get care is the emergency room, which is totally inappropriate. Not only is it inhumane because they're in there for 6 to 8 to 10 hours, but also they take up the time for people that are true emergencies. It's inhumane care. We're not starting from scratch. Obama said he didn't want to delve into single payer during health reform because we'd have to start from scratch. Well, that's totally false. Because all we're doing is expanding Medicare, which is a single payer program for those 65 and older. And I'm now a Medicare recipient as of a year ago, and it's a wonderful program. It's very generous. I'm a Stanford patient, so you can imagine the charges that they charge for the tests that I have. I'm one of the 1 million who went bankrupt because of health bills. I had to file for bankruptcy this spring because I had $12,000 of charges to the Palo Alto Medical Foundation just for tests, blood tests and a few x-rays. And I was being canceled for work because the economy has hit nursing. 50,000 people were laid off in Silicon Valley a year ago, and with it their health coverage. So they are not coming into the hospitals and having elective surgery, or they're waiting till they're very sick. Most of the hospitals now are Medicare patients because they do have coverage. So because the wards are empty, they're having to lay nurses off or cut their hours. A lot of people don't know that is going on. So because of that, I'm one of the pre-existing conditions, people where I couldn't get good coverage or it was extremely expensive. And I'm very glad I did file for bankruptcy because I couldn't have moved forward had I not. What single payer is an insurance program. It's simply a public insurance program, just like Medicare. You have 1.45% taken out of each paycheck for FICA M. FICA M is Medicare. FICA is Social Security for food and housing when you retire. So it's basically a publicly financed system. The people are opposed to single payer say it's a government-run healthcare system. Well, that's incorrect. It is an insurance system that pays the doctors and hospitals the same as Medicare does. We're just expanding Medicare to cover everybody. It is not socialized medicine. Does anybody know what true socialized medicine is? Yeah. Because that's commonly misunderstood. Socialized medicine is where the government owns the hospitals, the doctors, the nurses. The only 3 socialized programs, I understand Spain has one. The most famous is the National Health Service in Britain. And guess what? We have a socialized medicine system in America. It's called the VA. And so all these opponents of socialized medicine, we already have one that's actually very successful. I heard a doctor the other day say that the outcomes of the VA are getting better and better, and it's actually a pretty good health system. So basically, this is another term that's misunderstood, is universal health care. People think universal health care means single payer. It doesn't. All universal health care is everybody's covered, but it could be covered with insurance plans. So we like to say it's a universal health coverage with single payer financing. Single payers financing it. Most of the other foreign countries, all the industrialized countries, take out taxes by the employers and the employees, payroll taxes to pay for it, and that's what our bill has in it. It is a 5% overhead. Medicare has, and I've actually heard some people say Medicare has a 2 to 3% overhead.
It's about 3.
But I tend to go with 5 because it sounds more reasonable. It will cost less. Mark Leno said that we currently pay about $200 billion for health care in California. All we're doing is taking that money and putting it into health care instead of administration, marketing, profits and stuff. There will be no new taxes.
Can I just...
Yes.
In Canada, with the universal healthcare system, or single payer system, the overhead is less than 1%.
Is that right? Thank you for that statistic. That's pretty impressive. Everyone will be covered on a single payer. If you are a resident in California, you will be covered. So then people say, what about the undocumented? Most of them are here working because the countries they came from, there's not enough jobs. And they will be covered too. Anyone that is a resident of California will be covered. Now there's a concern that we're going to get a huge influx of people into California if this passes. There's actually a portion of the bill that deals with that. The health commissioner who heads the system will decide how to handle and what will constitute residing in California. If you're just here on vacation, you may get a bill if you're from a state that doesn't have single payer. But you have to prove that you're going to actually reside here, have an address, and such. As I mentioned, it is not free. In Sicko, Michael Moore's movie, he made the mistake of using the term free. We had free health care. And when you go to the doctor, you don't have to pay a copay. So in that sense, it's free when you go to see the doctor. But you've been paying into it through payroll taxes. Nothing in life is free. And there's a national bill, H.R. 676, that John Conyers is authors, and his program would be 3.3% additional tax on top of the 1.45 of Medicare, and same for employers. So theirs is a little less because it would create so much money, there'd be plenty to cover everybody. But because we're having so much trouble on the national level, that's why we're fighting very hard on this. We're probably going to do it state by state like they did in Canada. The doctors actually were very much against the program in Saskatchewan when they introduced it, but finally it was passed and they realized it was a good system, and then it spread to the other provinces. I'm saying employees pay 5 to 6% payroll in lieu of premiums, insurance premiums. So basically what we're doing is getting rid of the for-profit insurance industry that takes about 30 cents out of every dollar on marketing profits and denying people care. You can be uninsured and not have coverage, but you can be insured and not have things covered. I saw a woman testify in the Senate who had aggressive breast cancer. She was from Florida. And she said that Blue Shield denied her care, chemo, radiation, whatever was required, for this aggressive breast cancer because she had put down the wrong weight on her application when she applied. And by the time she protested it, and the CEO said she could get coverage. 7 months had passed, and apparently it had spread. That is the kind of travesty, and really it's immoral. It's an immoral system. Business will be paying approximately 10% rather than 16%. Right now that's 16% pretty much for the big employers. The small employers would find it a burden because of the cost. They do now. That's why they don't. Many of your uninsured are your employees of small businesses, where the employers just can't afford the current premiums. So there was a bill in the California legislature a couple of years ago that had it by payroll, $100,000 payroll. That employer would pay so much percentage into the single-payer system, and to me, that's the fairest way to go. I personally don't think that our original number was 8% because the Lewin Group came up with that number, but that was across the board, big business like Hewlett-Packard and then the small, and I didn't think that was fair. There's going to be a rich benefit package available to all, including dental, vision, and hearing aids. So the people that will benefit the most from single payer are those who are Medicare recipients, because they'll get their care like they get now, but they'll have dental, vision, and hearing added to it, which currently isn't covered. There'll be no more bankruptcies due to health bills. I don't know if did any of you see the movie Sicko?
Yeah.
Do you remember the couple, Donna Smith and her husband, that both had serious health problems, and it caused them to go bankrupt? They had to sell their house and move in with their kids. Donna Smith came to California a couple of weeks ago, and James Haslam from the Vermont Workers Center that got single payer passed in Vermont, and Donna, who's now working for Progressive Democrats of America and CNA nurses, came to help us in California. We had 10 events, how they were able to get their bill to a governor's desk and give us some tips on grassroots organizing. And she was one of the one of the million bankruptcies due to health bills. I mean, people have to sell their houses. It's a very dire situation. The key thing is the healthcare delivery remains private. The beauty of single payer is, once it's passed, you can pick any doctor or healthcare provider you want, just so the person's licensed. It includes nurse practitioners, physician's assistants, acupuncturists, chiropractors, doctors. And for instance, if there's a doctor at Kaiser you particularly like, but you're not a Kaiser member now, in single payer you can go to that doctor. So there's much more choice. You'll hear a lot of the naysayers say choice will be limited, but it isn't. You get total choice of who you want to see. Now, there is in the bill somewhat of a gatekeeper idea that you see a regular physician and they refer you. But there's also a provision, if you're currently being followed by a specialist for a specific disease within 6 months of the bill, you get to keep with that doctor. You don't have to go through the gatekeeper concept. And that's actually a good thing, because some people will just go to an orthopedic surgeon because they have a sore knee. But the whole reason to go to a surgeon is you expect to have surgery. And you may not. You might just have arthritis. So you don't want to waste surgeons or specialist times if you're not going to be a patient where you need their services. More money will go to healthcare, be redirected from administration. Better reimbursement for providers, no more middleman. The reason more and more doctors are joining the single-payer movement is the control of their practice. In California, there's about 6,000 different insurance plans that Kaiser might have 150 or 200 different kinds, and they have to have at least 1 to 2 FTEs, full-time equivalents, to process all those claims. Like, this insurance plan might cover this procedure, but not that procedure. And that's just a lot of waste of healthcare dollars that could go to patient care. No more deaths due to uninsurance. Donna Smith, when she came to do this tour of California a couple of weeks ago, said that there was a figure by the Institute of Medicine of about 44,000 people dying in America because they had lack of preventive care. That's a shocking figure. She just read a Commonwealth Fund report, and apparently they're pretty conservative. 100,000. They somehow, and how they find that number, I don't know, but they feel that about 100,000 people in this country die because they are denied.
Is that in a year? A year?
A year.
A year.
In a year. And no more excessive salaries. I don't know, United Healthcare, which is what AARP's plan is. I mean, I don't know, he makes $1 billion or something. It's ridiculous. No more inhumane waits in the ERs. And we will join all the other industrialized countries. Right now, the system that is touted one of the best is Taiwan. Dr. William Cao, who is a Chinese economist at Harvard, designed the Taiwanese system. And apparently it's working really well. Don't ask me questions about it because I'm not an expert on it, but it's considered one of the best because he was able to go around the world and see all the other single-payer systems and see what worked and what didn't work, and work with doctors and make sure everybody liked the system. He's the one that wrote the 3 proposals for the single-payer system in Vermont. They passed the single-payer bill, and the Governor Shumlin signed it. It's not true single-payer, but it is close enough. And that's why James Haslam of the Worker Center came to a meeting we had at the South Bay Labor Council and explained to us how they were able, how grassroots was able to facilitate this. The Quentin Young, who is a very famous doctor, he was one of the founders of Physicians in a National Health Program, head of the American Public Health Association, who's from Chicago, who has treated in the past Martin Luther King. His partner is Obama's doctor. They talked with him very adamantly to get single payer at the table, but Obama unfortunately refused. Quentin Young was in San Francisco, and Joan and I had the pleasure of being able to hear him speak about single payer. I'd say he's probably in his mid to late 80s. And he's seen the system over many, many years and people trying to get single payer. And he said that in most of the countries, it was labor that got the legislation passed. So he was basically encouraging all people in the labor movement to get involved. And that's kind of why single payer is now in Denver and New York as because there's a lot of labor working in the Occupy movements, and that's why single payer is now percolating up to one of the issues they're pushing, because it's like the Wall Street of the health insurance industry. On the table is the two-sided form of how the system will be run. And what's beautiful about it is that it's the stakeholders running the system. You've got doctors, you've got pharmacists, public health representative, for healthcare consumers, a labor rep, essential community provider, mental health care provider. They're the people that are going to be running the system, not a faceless bureaucrat. The health commissioner, who can have a term of 8 years, is selected by the governor. It's a political appointment. But the system itself, there's an Office of Patient Advocacy, which we currently don't have, where patients can actually go and file a complaint about their doctor or hospital. They have a public advisory board that advises the system on what they think would improve it. There are going to be 10 regional entities throughout the state, and they're going to have their own mini board of doctors, all the stakeholders, and that allows them to get money from the state and spend it within their region for the health needs of that region. Because as you can imagine, rural communities and city communities are going to have different health needs and where they should emphasize. If there's a high tuberculosis population in a certain region, then obviously they'd spend their money on that. But it's run by stakeholders, nurses, doctors, pharmacists, hospital administrators, and consumers. And there's also going to be an inspector general for single payer to weed out fraud. Because people talk about Medicare fraud where doctors double bill or they use the wrong 5-digit code and stuff. But you can't blame Medicare for that. they don't know. They just pay the bill. They assume the doctor's going to be honest. Well, they're finding there's a lot of Medicare fraud by unscrupulous doctors. This Inspector General will be focusing on that to find out any fraud and abuse. There'll be a chief medical officer who will try to encourage evidence-based healthcare. In other words, what treatment works the best for that disease, so that all patients can expect, if you go have an asthma attack in LA and you have one in San Francisco, you should be getting pretty much the same care, so that everybody gets care that is proven to be effective, so they can weed out doctors that don't abide by that. I have a sheet here. I didn't have an electronic copy of Obamacare. Obamacare does have a couple of positive things this year. It'll cover mammograms, as I understand, a wellness check, which they didn't cover before. Kids under 26 and under can be covered by their parents. There's a couple, but they're all incremental, and that's why there was a huge movement. Mad as hell doctors who got really mad that single payer wasn't at least at the table to be part of the conversation. So we need your help. And the current status of the bill is, because we're the state that had a single payer bill the longest, 20 other states are working on a similar thing. And that is that it is going to be heard in Senate appropriations in January, probably mid to late January. And the reason it had to go to Senate appropriations is in the bill, there's something called the Premium Commission. That's a commission, about 25 members of 3 healthcare economists, doctors, legislatures, to come up with a tax structure. The last structure, or amounts that Senator Leno has mentioned, is 10% on employers and about 6% on employees. But this health care premium commission would come up with today's dollars, what would be the most reasonable taxes to pay for the system. Now, we need 5 votes in Senate appropriations, and we think we have them because 3 of the 6 on that committee are either co-authors of SB 810, Elaine Alquist, and the other 3 Democrats have voted yes in the past. The fear we have now is the floor of the Senate. There are some new senators that are blue dog senators in California, Democrats. They're conservative. They're in districts that have a fair number of Republicans. And in order to appease them, there is rumor that some of them might vote no on the bill. In the last iterations we've had of the bill, where it passed through the Assembly and Senate to Schwarzenegger's desk where he vetoed it, there was only 1 senator that voted no the whole time, and his name is Lou Correa. He's from Orange County, very, very conservative. So I have little half sheets there in lavender of what you can do, and that is called Christine Keogh, the chair of Senate Appropriations, who is a Democrat, has voted yes in the past, and is her telephone number, and urge her to make sure her committee passes it to the Senate floor. Mark Leno, Healthcare for All, who wrote the bill, had a board meeting in Orange County on Saturday. And in talking to people that attended, I was unable to attend. Mark Leno has 20 votes. In the Senate, there's 40 senators, 25 Democrats, 15 Republicans, I believe. And because this bill has no taxes in it, it just requires a simple majority vote, 50% plus 1. So we need 21 votes to pass it from the Senate to the Assembly. He said he has 20 sure yes votes. So we're doing heavy lobbying of the other 5 that may vote no or threatening to vote no. There's also the possibility that if it is 2020, that Gavin Newsom, Lieutenant Governor, can vote, and he's for single payer. So it isn't as easy as it has been the last few years. We had much more progressive, numbers-wise, legislators. The good news is, because of the redistricting, we may end up getting some seats that were traditionally Republican and may help us get close to a 2/3 vote. We're keeping our fingers crossed on that. So get involved with getting people elected locally. And that's pretty much it. I'm open for questions and answers.
Do you have a list of those that need to be lobbied or have letters written to them that should vote yes but may vote no?
Well, yeah, we actually, this is new information
Okay.
from Saturday, so I need to find out. I think they are Ed Hernandez, Roger Hernandez, Michael Rubio, Rod Wright, maybe Juan Vargas. Ed Hernandez is the chair of the Health Insurance Committee, Senate Health, and he almost voted no with proviso. Turns out that he's been getting a lot of money from the health insurance industry. And Darrell Steinberg appointed him the head of that committee. Michael Rubio is a brand new senator from Southern California, from Bakersfield, from an area that actually has a lot of the uninsured. But Jim Costa, who is in Congress, a Blue Dog Democrat, came out for single payer, this is what I'm understanding, and he got threatened by the Tea Party. And Michael Rubio is the same district, and he's afraid of the Tea Party, apparently, and that's why he's waffling. What's interesting is usually they appoint people to committees based on their expertise. Usually it's somebody that has some healthcare connection, like Elaine Alquist has always had in long-term care and such. I looked on Michael Rubio's website, and there was absolutely no mention of healthcare whatsoever as being an issue that his Senate seat is addressing. So I was a little curious how he got appointed to that committee. What he did in the vote is he abstained because he was threatening to vote. And if Hernandez and Rubio had both voted no, it would have killed the single-payer movement that's been going on for 15 years in California. And so they got really strong-armed that you better not do that. You'll have a lot of angry people. I can get you that list because I want to know too. We have a new campaign for a Healthy California that is being led by the California Nurses Association, CTA, California Teachers Association, CRTA has been involved, the Progressive Democrats of America. Then there's another Progressive Democrat caucus.
Right.
That's out of Sacramento. I'm not as familiar.
The caucus is part of the Democratic Party. Unfortunately, they were not recertified at the last e-board meeting because of the position they took on endorsing an alternate candidate to President Barack Obama. And at our club meeting last night, we decided to censure their resolution, but to encourage the recertification of the Progressive Democratic Caucus, because we need it for issues just like this. They're willing to go far to the left to get these things done. And this piece of paper is just maddening. It just makes me furious.
Yeah, there's a handout there from an organization that we're just finding out about, the Christian Children and Family Protection Group or something. Association. And they have a very interesting take on 810. One of them being that they are going to, once 810 is passed, everyone in California is going to be given a psychiatric examination.
Which could be used against them later on.
Yeah. And that they're going to have euthanasia of babies and older people, that they're going to be killing newborn, in newborn ICUs, and they said like other countries. So they're pretty way out there. What's interesting is Irma Strantz, who's a single-payer advocate and leader in San Gabriel Valley, is very familiar with this group. They're a right-wing Christian group that doesn't believe in abortion.
Or preventive.
Yeah.
But it's really telling when they say what you can do. Write your state senator as soon as possible, and then under notes it says, write as a concerned citizen, and do not disclose the source of this alert. They will not take responsibility for putting this kind of crap out there.
Sounds like somebody needs some psychiatric evaluation.
Yeah. Well,
Sorry.
you know,
Yeah,
and
yeah.
it's full of threats like that, just as you were saying, Lynn. And this is why we have to be as active as these nutcases are, or twice as active in writing our legislatures and supporting this bill.
Yeah.
So I have two questions. One, I think you touched on with the funding of the bill. Now, I understand the bill itself doesn't have any taxation in it and doesn't really address funding.
Correct.
And my understanding from what you said was that the money was going to come from what would have been spent on premiums will now go into this fund for universal health care. My only concern with that would be there would be quite a few uninsured people who are not currently paying into or paying any health care premiums. Yeah, where would the money come from to get those folks covered?
Okay, I wasn't quite, didn't give you a full disclosure of the funding. Half of the funding is coming from Medicare, Medicaid, S-CHIP, all the federal funds that currently come into California, and any local money. The other 50% is what the single payer taxes will pay for. And everyone will get care even if they can't pay into the system, just like they do now. The homeless, people who don't, they'll have access, but they'll have preventive access rather than being forced to go to emergency rooms.
So that really helps answer that first part. The other part, in reading the bill, and we briefly talked about it, I was very concerned that there's, I think in the preamble of it, an exclusion of folks who are covered by the collective bargaining process. And that was very concerning to me because what I'm hearing is that the intent is to have a single payer system, an even playing field for all people in California. And by excluding collective bargaining, people who are covered under collective bargaining, you're already setting up a two-tier system.
Right, as I explained to you when we first, I am not familiar with that wording. There in the bill, there is, that addresses collective bargaining agreement contracts, employee contracts, I think is how they call them. And that is the plan, single payer will cover everybody, and if the employer has a better plan than single payer, they can certainly have that. I.e., they would cover plastic surgery, which we don't cover, and long-term care. They could offer their employee a better plan. They also may be willing, if they're a good employer, to pay the employee payroll tax as well as their own. However, the way the trend is now, employers are trying to make the employee pay most of the premium. But I'll have to go back and read the bill again because I'm totally unaware of anything excluding anybody.
Yeah, I haven't read the bill, so I don't know the details, but I've been following this for 2 or 3 years anyway, and at least in earlier versions, I've seen literature that said that employers, especially public employers like school districts and cities, would save a ton of money because they wouldn't have to provide as much, for benefits. So can you comment on that?
Thank you very much for bringing that up. A lot of labor unions are backing 810 and pushing it forward. One of them is the California School Employees Association. And for those who aren't familiar, they're the people that are not the teachers.
The bus drivers and custodians and so forth. Yeah.
Right, supportive staff and that kind of thing. They spent money, and I'm sure it was a lot of money, to do exactly that. They analyzed every school district in California and came up with what the savings for each school district would be.
I've seen those figures. I mean, 2 or 3 years ago, I just saw them.
Yeah, Cindy Young, I was actually at an event at the South Bay Labor Council where she had the box of all the different school districts and how much each one would save.
Yes.
And so they've gone to some of the school districts to explain that. When we did have a tax bill, way back, was Bill 1014, when we were trying to push forward, I think it was 8% employer, 4% employee. The man testifying for it was from the LA Unified School District, and he gave the huge figure of millions of dollars to be saved because of single payer, and why these legislators should pass the tax bill. But that requires 2/3, and we've never been able to get that. Hopefully, if they get this premium commission, the reason it is to go to Senate Appropriations is whenever you're appropriating money, a bill has to go through that committee. And the salary of this premium commission, which is in the bill, all the members, 3 healthcare economists, doctors, legislators, legislative analysts, their salary is about $1 million to pay them to do their work to come up with a tax structure. So Schwarzenegger vetoed it, so we were never able to get it implemented.
It's passed the legislature at least twice, right? And been vetoed by Schwarzenegger at least twice.
Right. It went through the Senate the 3rd time, went to Assembly Health, passed, but John Perez, the Speaker of the Assembly, stopped it before it went to the floor, claiming that it would affect the elections that year, which would be last year, I think, in 2000. It would affect the elections because of the Tea Party. They were really afraid of backlash if a assembly person or somebody supported single payer, that they'd have a difficult time getting elected. That was his excuse. We knew that if it had, even if it had passed, the Governor Schwarzenegger would veto it a 3rd time. He just never had a chance to because, so that would be 2 years ago, right? 2009.
2010.
Oh, 2010. Yeah, it was
almost
2010.
2 years.
Yeah,
As
right.
soon as it turns 2012, in a few months.
And the bill has pretty much been the same the whole time. It started as Senate Bill 921, then it was 840, then it's been 810 twice. And it will stay 810 for this year because it's a 2-year bill. It'll keep the same number. Yes.
Is there a provision for cost containment?
Yes. Unlike the Obamacare where there's no mention of cost containment, one of the ways they figure they could save money is preventive care will save about $3 million, getting people their chronic diseases like diabetes, heart disease caught early. That'll save money. They're going to do bulk purchasing of drugs and durable medical equipment. That will save a lot. So in the bill, and it actually says if the funding for some reason doesn't quite come up to what they want, the commissioner has the ability to either cut back a couple of benefits. I mean, there's a way that he can get it so that it does stay within the cost. The problem is the transition. Right now, according to Senator Kuehl, when she held the bill, there are about 6,000 different insurance plans. We're going to take 6,000 and reduce it to 1. So you know you're going to have a whole infrastructure of IT to get the computers to all talk to each other. That's going to cost money. Originally, they thought it would be a 2-year transition. Lately, they've been saying they think it might take 3 years. If we can if we pass it in California, and there's a bill on the federal level for a waiver, but that's not till 2017. So Vermont's bill, and if ours passes, at the present time, couldn't even be implemented till 2017 when that federal waiver will be available. There are bills at the national level to try to bring that date from 2017 to 2014. I'm not sure of the status of those bills, but there is a push so that when the exchanges take effect, a single payer program in a state can replace the health benefits exchange if it's as good as or better than the exchange. And California is the first state to actually create an exchange because Elaine Ahlquist had a bill, Schwarzenegger signed it the irony is the people that serve, the 5 people that serve on the board that are creating this health exchange, none of them have medical backgrounds. They're all lawyers or politicians, or so that's unfortunate.
And I just wondered if there was any part of the single payer provision that provided for relief from the high cost of pharmaceuticals, drugs.
Well, they'll be bargaining with the pharmaceutical companies
Okay.
to get good prices.
Because
Because Kaiser already does it. Kaiser and the VA buy medications in bulk and get big savings.
And they pass those on. I mean, my husband takes a medication that I also take. He pays $10 a month, and I pay much, much more. And I've had to buy drugs out of Canada because of the high cost.
But Kaiser actually has a better plan for that than Canada, because it's cheaper for my son to get meds here than he's in Canada. He's a Canadian resident.
I'll be darned.
Yeah,
It's cheaper to buy them through Kaiser here than for him to
Yeah,
get them in
I
Canada.
believe that.
Apparently medications are not covered, is that right,
No,
by
it's not.
their program? Yeah, I'm lucky with Medicare. I have this prescription solutions, and my Part D is through AARP, and I pay for 90-day supply of medications for $4 to $8. Yeah,
Some
it's pretty
medications
good.
are like
You know,
that.
the statins, they're all generic, but they're just as good. And before that, I was getting from Canada, and people say to me, it was kind of fascinating to look at the box, like one of my statins was made in India,
Right.
one, Lipitor was made in Turkey, I think. And they said, you mean you're taking medications from another country? You know, how can you trust them? I said, well, they're all living over there as far as I know. And that actually India is becoming a big, the healthcare field and pharmacy is becoming a country that's booming with that.
How would this fit in with the national health care law? Does one supersede the other?
Well, that's kind of what I was mentioning, the health benefits exchange. That has to be up and running in every state in 2014. And that's the one that will, it's 2014 when the insurance industries can no longer consider pre-existing conditions. Up until then, they can, and they've got a 2-tier structure now where the premiums under the health benefits exchange for people with pre-existing conditions is higher than the people that don't. But in 2014, they can't do that anymore. And so it's, and the Obamacare doesn't cover everybody, where a single payer does. So that's why we're looking to 2017, or maybe even early 2014, to replace Obama, the current healthcare system. And little things are being implemented month by month from Obamacare. Of course, we have to look at the Supreme Court. It's now gone to the Supreme Court as of, what is it, today or yesterday?
They got it yesterday, but they didn't know when they'll come up with a ruling.
See, they,
Is what they're predicting.
well, in the meantime, whatever it does say will be implemented until they.
So can you explain, if California should pass this, how would it be accommodated under the federal program?
It would replace it.
It's allowed, right?
Yeah, it would replace it. So the money, like I said, half the money coming from Medicare, Medicaid, S-CHIP, State Children's Insurance Program, and all the federal will come into the state. The employers and employees will pay the taxes. There might be, in one of the iterations, there was a talk about a small tax on stocks and bonds as a revenue stream. And then, so that 50%, and then we would do the single payer system here as it's written.
What about all the other sources of health care, such as the Public Health Department, the Veterans Administration, and other places where people get their health care now? If they should be covered by a single payer, wouldn't the expenses for those entities go down?
That's a good question. I do not know the exact answer, but my understanding is the VA will stay the VA.
Probably, because they have
There's
a
a
good
special
political lobby.
Yeah, there's a special population
Right, they
that
are.
gets funding from the federal government.
But,
But if the procedures are going to be, if it's single pay, I'm kind of fuzzy on the procedure part of it. So in Canada, my sister-in-law was an OB-GYN. and she would get patients in, and she's paid a set amount for every office visit, every delivery she has, if there's a problem, blah, blah, blah. There is a fixed amount that she would get paid. That's the way it is with universal health care, and that's fine. That's the way it works. So I'm assuming if they had something like that, and I'm not saying the VA is going to have that kind of an issue, but if they're giving you X number of dollars for a heart transplant or whatever, wouldn't that be right across the board? Wouldn't matter who's providing it? Wouldn't that be,
Yes.
shouldn't that be true for the
Yeah.
VA or the public health, or if you're going to see Dr. Smedegoff
Well, I don't know
or
about
whatever,
the
right?
VA. I'm sorry, but I'm not an expert on how the VA works.
Yeah.
With
I'm
single
just-
payer.
so the
But,
way
but
I
everyone else, outside the VA, a non-veteran would get the, you know,
It would
if
be
you were
a
a
standard
homeless
procedure for
person or.
a set amount of money, which is the part of the reason you're able to bring the cost down, right? I
And
would
that's the way
presume.
Medicare works now.
Yeah, and
Yeah.
that's the way it should be.
A Medicare patient goes in, has a procedure, and without complications, straightforward, the doctor, the
Gets
nurse
paid
writes
X
down a
number of
code,
dollars.
and they send it to the government,
Right.
and then they get 80% of that.
Right, okay.
And if you don't think that there's money in big business in supplemental insurance,
Oh, sure.
I mean, we've just been hit with Humana and AARP and all these supplemental policies to cover that 20% that Medicare doesn't pay. There's huge amounts of money.
Right, and that will all be covered under.
Yes.
The other thing is, I forgot to mention, is physicians wrote Chapter 6 in the bill, which is delivery of care. And because physicians wrote it, they wrote it in a way for how they would get reimbursed. And that's why these regional entities are good, because a certain amount of money, and I think, if I remember this, as fee-for-service or a capitated amount like a Kaiser system, an integrated healthcare system, the state would give them a bulk, a chunk of money, and then they'd figure out how to spend it. And my understanding, I've heard that I know you're in solo practice, that they're recommending that physicians join a group practice before single payer because it would be more cost effective. And of course, one thing about the Kaiser system is it covers their malpractice. So it's kind of a good deal for Kaiser doctors.
That's a huge difference between the U.S. and Canada. I mean, my sister-in-law she's retired now, OB-GYN, and the fraction she paid for malpractice insurance is a fraction of what her friend pays in Portland in the U.S. They have a huge amount that they have to pay for malpractice in the U.S. because people here are nuts.
Yeah, well, that's why
they are. It's just insane.
That's why a lot of OB/GYN dropped their OB practice and just became gynecologists.
And part of what you're talking about is a different business structure. Kaiser is an organization that employs physicians, whereas in my practice, I own the practice. So I think for the thought to be out there for solo physicians to just say join a group, that'll be awfully difficult for those of us who have had our own practices. I know a lot of the younger physicians coming out don't even think about going into private practice, solo practice, because it is so difficult. My other question though, what I'm seeing in the medical literature is that there's going to be right now, there's going to be a shortage of primary care doctors in the foreseeable future, in the next few years. We're already seeing it. With this being enacted in California, how are the patients going to be seen? Where are the extra doctors or the extra visits going to come from?
Well, that's certainly a very valid question. Number one, my understanding is the American Medical Association is the group that has determined physician salaries in America. And they have, I've heard this, and that's why specialists make a lot more money. And when you talk to med students or interns coming out, they are going into specialties not because that's what they want to do, but it's more money to pay off their huge med school debt. I heard on one of the hearings of family practice, I think it was $160,000 a year. I mean, that's a third of what hospital administrators make. and they're physicians. I trained as a PA at Stanford like, I don't know, 30 years ago when there were hardly any jobs available. But you do have your mid-level practitioners that will help because they are licensed and they can do a lot of the chronic care. But that's certainly a legitimate question, is we need to get more doctors. And I think, and don't quote me on this, but I think in the bill it said something about an extra incentive for doctors to go into underserved areas. I believe that's in the bill. The bill has thought of everything. It even thought of what to do with the displaced workers when the insurance companies are being, closed. Now we'll need many of the clerks because we'll have that many more, 8 million more people having to have claims processed. So the clerks, the clerical who know how to do all the CPT codes and stuff are definitely going to be in high demand.
Are we going to find positions for the CEOs that might be out of the job?
Well, let's put it this way. I'm not worried about it, are you?
I feel sorry for you. Exactly.
Hi.
We've talked about contributions by employers and by employees. What are the considerations for the large number of baby boomers that are leaving the workforce over the next decade that will want care and aren't paying anything because they're not working any longer?
Good question.
They're moving up into Medicare anyways, right?
Yeah, I would
You got the program in one way or another.
That's where the premium commission, who hopefully will convene soon, will have to, that's something they'll have to deal with. But Mark Leno always says there's already $200 billion being spent in healthcare in California, and there will be no new taxes. It's just the money, instead of going to Kaiser, Humana, or Aetna, it goes to the state to pay the bills. And there's plenty of money there to cover. And the first couple of years of the bill, they don't anticipate co-pays or deductibles. Yeah.
What's the California Medical Association's position?
They are a subset of the American Medical Association, very conservative, and they are anti-single payer. And they've always, the groups, when I go to hearings in Sacramento for the bill, I like to go when there's big votes happening. The line of supporters is like a mile long, going up to the microphone. I support, I support, I support. And then you come to the opponents, and there's like 5 people who come, and they're always the same. Chamber of Commerce, California Medical Association, and all of the insurance companies, this insurance plans. Those are the Kaiser last time voted no. It was an opponent, but this time hasn't come forth. See, the Kaiser system is actually a model for single payer.
It is.
You can plug the single payer
Close to
system.
Medicare as you can get without being on Medicare.
Right, and it really is a single payer system if you think of it. You pay Kaiser and you get your stuff. The Medicare Advantage is one of the best, just rated the #1 because the premiums there are like, I talked to someone like $75.
Yeah,
and you
that's
get,
right.
yeah, isn't it about, yeah, it's amazing. And I had considered it when I was inundated. When you're 64 and a half, you get a pile of mail this size with every company wanting your business. And it sounded very inviting because of the cost, but all my doctors have been at Stanford, and it was just difficult for me to move from doctors who knew me already to another group.
Well, then, is some retirement benefits, like for ex-IBMers, retired IBMers, which my husband is one, the retirement actually writes in that the preferred supplemental insurance to Medicare on their retirement plan is Kaiser. And quite frankly, I love the Medicare I get, but it costs me more for my health care on Medicare than it does Ned, because he gets his every prescription, no matter what it is, for $10 a month. And I get 90-day supplies, and it depends on the manufacturer. And one of the more life-saving drugs that are really coming into use are corticosteroids that are built specifically for a site of inflammation, so you don't get all of the side effects. But 500 or a 30-day supply for me was $735 under Medicare Part D, and I got it in Canada for $238. So there's a huge discrepancy. For him, a corticosteroid would be $10.
Is that generic or?
No,
does it
it's
have
only
to be
made
generic?
by AstraZeneca. And you can get help from these companies, but you have to send them crates of personal information to do it, taxes and all this kind of stuff.
Lynn, I have a question. What is the California Medical Association's major objections? You said you've got 5. I can understand all the other ones real clearly. Tell me what their major objection is.
Probably
Because they're still getting I presume they're getting paid per procedure, and so I'm using the new one, right? And this group is somehow setting the rates for each procedure, right? So is it that they feel they're not getting as much, or what?
You mean the CMA is setting the prices?
No,
No.
I'm saying with the new plan.
With the
that's
new
how
plan,
they bill.
right.
Are
So
they
tell me
afraid
what
they're
is-
going to get stiffed on the amount they're going to get reimbursed for what they do?
Or what is the
That's probably, I would guess. I've never actually
Curious to know.
Yeah. I'm sure it's because of reimbursement. They don't think they're going to get as much as they do now.
I can answer some of that. I think one is the reimbursement. Some of the groups can negotiate better rates with certain payers. They can almost corner a market, so they can negotiate better rates in an area with a certain payer. The other thing is...
So you're saying they'll work with an insurance company to get a better rate?
Oh, yeah.
So then the insurance company turns around and,
Yeah, so that's one part of it. I think the other part of it is just, as you mentioned, the gatekeeper phenomenon, which we saw with the whole HMO movement. That's going to reduce the number of referrals, and that's going to reduce the number of patients that specialists see.
You know, but in Canada, you sort of have that anyways. As you know, when my kids were little, we were there. We had our general physician that we saw, and if there was something that was really wrong, we had to see a specialist, and we'll go see this person.
Right.
And they had a number to pick from me, and so, but she would recommend one. So you wouldn't go right away to see your orthopedic surgeon for your knee. You go see your general GP anyway.
Yeah.
Right?
But people have gotten used to, well, I have a sore throat, I'm going to go see the ENT. Or I have a sore knee, I'm going to go see the orthopedic surgeon.
yeah.
So I
we
think-
should retrain them anyway, though? I mean,
Do I think we should retrain our
Patients?
Patients, yes, I think so. Okay, I totally agree. I don't do that in my
Yeah,
office.
yeah.
You know, I welcome them into my office to get the care that I can provide. So, but I think those are huge issues, and that's why the organized medicine is pushing against it.
Right. Well, the Physicians for a National Health Program, who are the physicians that are pushing it, that their numbers are increasing. And the Journal of American Medical Association a couple of years ago released a figure that 59% of physicians in America want single payer. There's a lot of people that want single payer. It's just that the politicians are paid by the health insurance industry. They're not listening. Max Baucus in Montana is very conservative. He headed the Senate Health. And they did town halls all over Montana, and all of them want single payer. So it's just that the politicians are not listening to the constituents. We're hoping maybe the Occupy movement might increase the interest and knowledge about single payer, because it certainly, every day there's more and more people turning out for these rallies. So I think a momentum has started.
Afraid it'll do more damage
So
than
going
good.
back to the CMA thing, then, you talked about them saying they're going to lose control. But don't you think that the doctor's not having to argue with an insurance company for what kind of treatment their patient should get? Don't you think that's a big positive that would make them want to support something like this?
I think in theory, the reality of Medicare, the reality of Kaiser, is that you're limited. So I may believe that this person needs a certain test. For example, what came out, was it earlier this year or last year, the panel said, well, women shouldn't get mammograms till age 50, and then it should be every 2 years. Well, the women's groups fought back against that, and I was really angry, and I still have women asking me, do I really need a mammogram at age 40? And it's yes, absolutely, every year. So what happens is physicians will lose control because I have a way that I believe very much preventive, but the people who make the guidelines up may not agree with the way I think. Okay, they may be influenced by other factors. So those guidelines are used to kind of dictate how medicine will be practiced. And I think a lot of physicians don't want to lose that independence.
Well, thanks for your interest. If you are interested in updates on single payer, sign my sheet over there. I have an email list where I keep people involved in events coming up. We're doing tabling at the Abilities Expo in San Jose this weekend. Sounds like a wonderful opportunity. They're showing all kinds of new resources for including horses and animals, and so we're real excited that we're going to be tabling there. But if you want further updates, feel free to sign up.
Marty is telling us that our tape is almost
But
over.
no, continue
So
on. I can.
we wanted to thank you for, we have a little something for you. Thank you for coming and talking to us.